Hello, welcome to week 1 of the Certified Nurse Aide training course. This week we are covering Unit 1 through Unit 5, and this PowerPoint is an overview or a summary of the material that you had assigned. This course is a preparatory course to learn basic nursing tasks and to gain certification in the state of Kansas. A minimum of 75% is required, and it is designed as a pass-fail course. Once you have successfully completed the Nurse Aide course, you will be scheduled to take your state exam. The state welcomes anybody to education and does not prohibit education. However, certain criminal convictions will prevent employment in adult care centers and potentially other health care settings. A list of the prohibited offenses is provided. If you have any questions or concerns, please speak to your instructor regarding that list. Unit 1 is about OBRA 1987. OBRA is an abbreviation that stands for the Omnibus Budget Reconciliation Act, or the Federal Nursing Home Reform Act that was passed in 1987. This was a result of complaints by consumers and customers about the poor nursing care being given to individuals in long-term care centers. This created sweeping reform that improved the quality of care for individuals. Prior to 1987, there was no minimum standard for education or training for staff working in long-term care centers or in other health care settings. This law said that in all 50 states they needed to develop a program of training that was at least 75 hours and that a competency test needed to be completed following this. In the state of Kansas, the Certified Nurse Aide course is written as a 90-hour course, and then your state exam demonstrates that you have comprehended and have the knowledge and applied the skills learned in this course. OBRA also established resident rights. This was a document that stated what the rights were of somebody that enters into a long-term care center. These mainly address quality of care and safety. Some examples are the right to privacy and dignity, and the right to have medical information, the right to have a proxy if they're not able to act on behalf of their own resident rights, the right to be free from abuse and neglect and restraints, and there are many other resident rights in the document. This is provided for you in your reading, and you should be familiar with these because this is the basis for the care that we give. OBRA required all facilities to establish an interdisciplinary plan of care. A plan of care gives us direction and tells us what needs this person has, and therefore we can be sure to provide for their safety and well-being. Interdisciplinary means all the different departments and services that are being provided, so we would have possibly therapy services, dietary, social services, activities, physician services, and of course our nursing services. OBRA also said that in order to provide a quality of life to individuals living in nursing facilities, they needed to have a home-like environment. We're going to talk a little more about this in the next slide, but this is what began the culture movement. In Unit 2, we'll discuss the aging process. Aging is normal, but disease is not, and many factors affect how somebody would age. Everybody ages at a different rate, and this is based off of their family history and their genetics, and then certainly their own lifestyles that they have led. When somebody retires, they have a change in their financial status and in their social status, and this can affect their overall health status, especially as they continue to advance in age. If someone is no longer able to drive or go to church events or participate in activities that give them well-being, it certainly affects how they go through the aging process. When we look at stereotypes about aging, we look at those in our society. Many people feel that elderly people are isolated or alone, or that they're ill or disabled or poor or living in nursing centers. In fact, only less than 5% of people that are elderly are living in nursing centers, so most of the elderly people are living in our communities and in our society, and we need to look at our own stereotypes that we have about elderly people because it colors our vision and our ability to care for somebody of advanced age. Another commonly held assumption is that old age starts at the age of 65, and that is because Medicare benefit, the federal insurance benefit, people are eligible for that at the age of 65. However, I think we all know people that are 65 or older that we would not consider to be an old person or somebody that is at advanced age. When we're looking at aging, we're looking at chronological age versus biological age. Somebody that is 65 years old that has had possibly prior health issues, say diabetes or high blood pressure, may have mobility issues, and these things certainly affect their aging and their ability to care for themselves. And then we may all know somebody that's 65 or older that is highly functioning, that still working, exercising each day, fully active. And so chronological age, which is our age in years, is not a true reflection of our biological age or our physiological status in our bodies. With our aging population, we are looking at our baby boomer generation. These were post-war children that were born when soldiers returned home. And this baby boomer generation is turning 65 and have turned 65 and will continue to over the next 15 to 20 years. This population of advancing age in our society has brought concern about how will we care for all the individuals that are going to be possibly needing care. People live longer today. Our average age of a female is 80 years old, and our average age of a male is 78 years old. So back many, many years ago, people didn't live past the age of 50 years old at the turn of the century in 1900. And so we didn't deal with things such as chronic illnesses. But because of our advancing healthcare and advancing technology, people live much longer today. And with advancing age comes chronic diseases. We'll be studying many of these chronic diseases when we get to Unit 15. The baby boomer generation also has a much higher expectation of what that care will look like for them and for future generations. And this is driving our culture change. The OBRA Act that stated that we needed to provide quality of life in our extended care facilities and that this needed to be in a home-like environment created a culture change movement that you can find information on regarding different models that were established. There's more information on page 8 regarding these models. One was called the Eden Alternative. It was one of the first ones. Greenhouses, person-centered care. These are all terms that we use now to describe culture change, which is moving away from the white wall and strict time frames of providing care in institutions and moving to a long-term care setting. When nursing homes were first established, they were based off models of hospitals, which were very sterile environments that had regulated time frames. These are for people that had acute illnesses, acute meaning serious illnesses or injuries, and that resulted in them going to the hospital, and they needed stabilization and medical issues, and they needed diagnostic care. And people living in long-term care centers are medically stable, and they're residing there, and so it's a different environment, and it needs to be a home-like environment. To gain an understanding and to apply care to physical and psychosocial needs of the elderly, we will look at Maslow's hierarchy of needs model. As you can see, this diagram has a pyramid shape or triangle shape, and there are 5 stages in this model. Maslow was a psychologist who developed a theory that prioritized every human's basic needs. So at the bottom of the model, we see that the very first basic need that individuals have would be the need to have air and to be able to have food and drink, and that, according to Maslow, people would not be able to progress or have fulfillment to other levels without first having basic human needs met. If those needs were met, then another basic human need would be safety and security, feeling protected and safe in their environment. And so this gives us a holistic approach to our nursing care. Holistic meaning providing care on all levels that an individual has for basic needs, not just physical levels, but things such as emotional, mental, and spiritual. And in nursing, we still use Maslow's model as a concept of how we would provide a holistic approach to care. In your material on pages 3, 4, and 5, the book does a good job identifying ways that a nurse's aide can assist residents with these basic human needs. So, for example, under biological and physiological needs, which is our very first tier on the bottom, for example, if somebody is short of breath or is in need of air, then there are things that we can do, such as making sure that they're positioned well, that they have oxygen, that it's working correctly, and anything there that we can assist for comfort. Safety and security, an example that's given there is the call light, which I think is a good one. If somebody puts on their call light because they need assistance and then nobody comes for 30 or 45 minutes, that does not provide a safe and secure environment. That resident does not feel protected, and they're dependent on somebody to come and provide care for them. And so if that need is not met, it would be difficult for them to move into other realms of their basic human needs. In Unit 3, we're talking about the role and responsibilities of the nurse's aide. This primarily centers around providing personal care and the activities of daily living for people that are not able to do that for themselves. So such things as bathing and hygiene, toileting, physically moving them with transferring, and then providing assistance with their meals. Other areas of responsibilities would be the resident's living space. We are responsible to keep that picked up and tidy. We also would be providing assistance with food, service, and meals. Record keeping and documentation. It's very important, documenting all the different care that we give throughout the day and the response that the residents have to that care. Communication with our residents, our families, and also with our charge nurses. Attributes of a nurse's aide. Things that make a good nurse's aide is having a good attitude, providing teamwork, dependability, coming to work, good personal hygiene, representing a professional manner, good communication skills, and then maintaining confidentiality and respect, which is our resident rights. And again, those were federal resident rights that were written during the OBRA 1987. One of those is HIPAA, confidentiality. Most of us are familiar with HIPAA through our own healthcare providers. This is Health Information Portability and Protection Act, and this protects people from their personal health information being shared with people that don't have a need to know that information or are providing care to that person. When we go to a doctor's office, we have our health information protected. We expect that professional not to be sharing that information with others that don't have a reason to know it. We also expect that that healthcare provider would not post information regarding us or pictures regarding us on Facebook or any medium that would violate our protected health information. As certified nurse aides and as students, when we go to the long-term care center, we also are obligated to that same law. Therefore, any communications that would violate their personal information need to be reported to your instructor. If you have any concerns or if you're unclear, then you need to talk with the instructor regarding that. You also have an agreement in your material that you have read prior to going to the clinical site for your training. Legal responsibilities for the nurse's aide again go to our OBRA 1987 resident rights that state that the resident is to be free from abuse, neglect, and exploitation. We have an obligation to protect all the individuals in the long-term care center, and this is from anybody, including staff, potentially their own family members, Unfortunately, sometimes there is abuse or exploitation, and any other party that would come into the building, even residents from other residents. These are things such as physical and verbal abuse, neglect, which is the failure to act prudently as a caregiver would do, a reasonable and prudent caregiver would do, and exploitation is referring to money and personal property. Any concerns immediately go to the charge nurse because those are reported to the state and a full investigation is done. Not only concerns that you would have personally, but anything that's told to you by the resident or a family member or another staff member that you feel might fall into the category of abuse, neglect, or exploitation should be taken to the nurse immediately. An investigation will be done to see whether or not those allegations are substantiated or if they were unsubstantiated. One way to prevent negligence would be to follow a plan of care as part of our daily routine. The plan of care is a roadmap, and it gives us a picture of each resident and what their specific care needs are, and then what we can do to be sure that they are safe and that their well-being is being cared for. So a sample plan of care is here for us to look at, and this is based off of information that's obtained in the minimum data set, which is called the MDS. The MDS is a data collection tool. All departments participate in this that are providing care for that individual, and this is coordinated by the registered nurse. Once all that data is collected and put into the database, then this gives us a picture of what type of problems this individual has. So for example, once the assessment's completed, we have identified on this scenario that a problem for this person would be risk for falls due to weakness from a recent hospitalization. So we want to plan a goal for them. The goal might be that the resident would return to their prior level of function within the next 30 days. Now these are goals and these are things that we would like to see happen, so this is what we'll be striving towards. In this scenario, in parentheses, it says this person was living independently and that they were ambulatory, which means they were able to walk. So now we know what they were able to do before they went to the hospital, and our goal is to get them back to that level. In the action phase, this is our specific steps on how we would make that happen. So we'll look at a couple of these here. One might be that we would have the resident in a room closer to the nurse's station. This gives us increased visibility, and we can respond to them to be sure that they're safe and they're being monitored. Another might be to assist them to the bathroom, to maybe prompt or ask every couple of hours whether or not they need to go to the bathroom. So many falls occur around people's toileting needs that being sure that we're addressing their toileting needs and assisting them to the bathroom will prevent them from trying to do this alone. And then, as you can see, there are other steps listed. The evaluation piece then is we need to go back. This tool is ongoing and fluid. It's not a static tool. This should always be representative of the resident's particular care needs at the time. So in evaluation, we would go back and look and see, did we meet the goals for this person? Did we not meet them? Do we need to revise them? Did they partially meet them? So this is continually being worked. Now this care plan process, when this is done, there is a meeting, a care plan meeting that's held, and the different disciplines are present, as well as the resident is invited and the resident's family is invited. And the registered nurse will coordinate these meetings, and they sit down and they go over this plan of care. Now in this scenario we just have the one problem identified, but in most situations there would be, other issues here that are being addressed as well. In this situation we see that the resident had successfully met their goals. They had not had any falls, and they were functioning at their prior level before going to the hospital, so they're scheduled for discharge. So this would have been a goal met. Unit 4 focuses on effective communication. Communication is an important role and responsibility of the nurse aide, and your book has information regarding actions and responses and tips on how to promote effective communication, not only between you and your residents, but between you and your coworkers and your charge nurses. Some basic things such as your verbal communication skills and your nonverbal behaviors are all factors relating to effective communication. When we're communicating with our charge nurses, we want to be sure that we're providing factual information that's not colored with our opinions and feelings about a particular situation, because that can affect what the charge nurse's perception of the situation is. Another thing that can be a challenge for us is not only are we communicating information back and forth with our residents, but sometimes there's barriers such as hearing loss or vision loss. Maybe they've had a stroke and so they have speech impairment, or they have dementia and therefore have some confusion and their perceptions are not correct in what is occurring around them, or they may have language barriers. And these are all things that present additional challenges to the communication efforts that we have. Of course, our communication, like I said, includes verbal and nonverbal on our part, but also we're monitoring and watching our residents, listening to them, allowing them to express feelings, and we're watching nonverbal behaviors as well. This is how we pick up on things going on with them and can provide information to our nurses. Keep in mind that anytime you are working with your residents and families and they have questions or would like information regarding medical information from their charts, the nurse would be the one that could talk with them, and you can direct them to the charge nurses. One way to promote an effective communication is to answer call lights promptly. In building trust and building a relationship with your residents, one of the best ways and most effective ways to do this is to be responsive to their needs. Unit 5 is infection prevention and control. We use infection control methods all day long in our practices. They're important because they reduce the number of microorganisms or pathogens that are present that could be transferred from one person to another person or one place to another place. Microorganisms are present everywhere, but some of these are capable of producing disease. These are our pathogens or our germs. These are viruses and bacteria and fungi. This is what causes infections. Elderly people are more at risk for these types of infections because with the aging process their immune responses decrease, and then if they have chronic illnesses or have been hospitalized, they have an increased exposure risk to organisms. Nurse aides are responsible to practice good infection control so that we can prevent any kind of secondary infections or nosocomial infections that a person might obtain once they've come into the healthcare setting that they didn't have prior to coming into the healthcare setting. One way to understand how pathogens can transmit from one person to another person through cross-contamination is to look at a chain of infection diagram. At the top of the diagram you see it says pathogenic microorganism. This is the source. This is the germ. To the right of that we have a reservoir. This is our current reservoir of where that germ is living. This could be a human, an insect, or an animal. Then we have a means of escape. This is how does that organism get out of our reservoir. These are through body openings or body fluids. This can be mucous membranes, broken skin, and once that organism has left the body, then there's a mode of transmission. These are described on page 22 in your material: direct contact, indirect contact, droplet spread, airborne spread, and vehicle spread. Once the organism has been transmitted, then it has the means of entry to another individual. The means of entry are the same ways that the means of escape are. So any type of body entry, orifice, broken skin, mucous membrane, these are all ways that that pathogen can enter another individual's body. Host susceptibility, not that that organism is there, it will grow if that individual is susceptible to that infection. And then we're back around to the top of that pathogenic microorganism. So host susceptibility comes into play when we're looking at our elderly people, because we've already described the fact that these people are at an increased risk because their immune responses are decreased. Now, the chain of infection anywhere along this link, these links can be, one link is broken, then that contamination won't continue around in that circle. So if we use hand washing, if we use gloves as a barrier when we're working with particular body fluids, if we use safe practices with the way we take linens off the bed and dispose of them into proper containers and not put those on the floor. And these things are things that will allow us to have good infection control practices and prevent the spread of pathogens. Some of these organisms have built up very high resistance to the drugs that we use to kill them. Some you may have heard of as methicillin-resistant Staphylococcus aureus, this is MRSA, and vancomycin-resistant Enterococcus, VRE. These are a couple of examples. These are drugs, these are organisms that are very resistant to the drugs that we have, and so they're virulent and they are highly contagious. Additional precautions are used when we have people that we have identified that have those types of organisms. Some terminology used when we're talking about infection control are terms such as clean and dirty. Clean refers to an area that's considered decontaminated or that has been disinfected. When we use a chemical spray to disinfect a piece of equipment or to clean a room where somebody's been discharged from, we are killing the majority of the organisms present. However, we're not killing 100% of those. That would be a sterile technique or a surgical asepsis. Clean refers to a medical asepsis, which is, again, a reduction in the number of organisms present, and this, of course, helps prevent the spread of disease. Contaminated or soiled or dirty means that the objects have been used. If it's a disposable object, then we would just toss that away. However, if it is a piece of equipment, then we would disinfect that prior to reuse. Sterile technique and surgical asepsis are also interchangeable terms, and this means that all organisms have been removed. These are done through autoclaves where they sterilize equipment, and they're completely free of all organisms. For the purposes of our Certified Nurse Aide training course, we will be learning clean technique procedures. Standard precautions apply to all residents. The best way to prevent the spread of infection and to break the chain of infection links is to do good hand washing. We've provided a hand washing video in your assignments to watch, and please note that in the video it mentions that the adequate length of time is 20 seconds for hand washing, and your CANS curriculum has an adequate length of time as a window of 15 to 30 seconds. The CDC fact sheet on hand hygiene is provided here for your review. This fact sheet gives healthcare personnel recommendations on when hand washing with soap and water is used and when alcohol-based hand rubs can be used. Personal protective equipment, or PPE, are gloves, gowns, face masks, respirators, goggles, and face shields. These are all products that we use to prevent healthcare personnel from exposure or contact with infectious agents. Standard precautions, which we spoke of earlier, include gloves, and we would use these with all residents in any situation where we might possibly have contact with blood or body fluids, mucous membranes, or non-intact skin. However, when we know somebody has a known infectious agent, then we will add transmission-based precautions, which are above and beyond our standard precautions. The type of precautions that will be in place are determined on the infection that they have and the method in which it's transmitted. Types of transmission-based precautions include contact, droplet, and airborne. Contact precautions, the pathogen is located in a body fluid. So contact with that body fluid would require the additional transmission-based precautions to be used. Otherwise, standard precautions can be applied. Droplet and airborne precautions require the use of a private room and masks for stricter control. You have completed the summary PowerPoint for Week 1. Any questions that you have from this presentation will be addressed in your lab session with your instructor. Thank you for listening.